Hello, everybody. How you doing? So I wasn't 100% sure what this format was supposed to be. So what I did was I stacked a few slides at the beginning just for general reference information. Then I got a bunch of cases. So we'll just roll through it a little bit. And if this is too much, tell me. We'll move on. So we'll get going. So, right, instability, right, as with any articulation. Think about bony stability, soft tissue, and dynamic, meaning muscular. It all plays a role in pelvic stability. Largely, these interosseous ligaments are the big things we think about for posterior ring instability. So when those are disrupted, we're unstable. Fair enough. The classification, they went over this a little bit yesterday. There's actually a formal agreement between the OTA and the AO. And it turns out that what we've agreed to is that when we reference this in the US, it's the OTA-AO classification. And when it's in Europe, it's the AO-OTA classification. So at any rate, so this is the OTA-AO classification. The thing I think that's interesting and confusing to people is that for the partial instability, the B1, the so-called open book of what would be an APC2 if you're in young Burgess, is in the same classification as lateral compression. Some people find that confusing. Then there's a young Burgess we mentioned yesterday, and we talked about that and had a good review. My personal favorite, and this is my preference, is the Buchholz system. It's either stable, it's partially stable, or it's completely unstable. I just like it better that way. Some people think that's old-fashioned, but that's my preference. So you can divvy it all up and do charts and all this nonsense. So that is a background. We're going to get into a case. So we've got a patient, 56-year-old male. He's T-boned. For those of you who aren't from the States, that means you're hit from the side by a car, and so he's got this lateral impact. He's hemodynamically stable, minimally mobile, so you're trying to examine him, and so you squeeze the pelvis in and out. When you go in, maybe there's a little motion. You go out, there's really nothing. Tender with palpation on the sacrum on his left side, and neurologically intact. So here's our AP, and the CT, we're going to just tell you, shows an incomplete sacroiliac fracture on the left side. So any thoughts from the audience? Anything you see? You've seen this fracture before in your emergency room?
Steve, when you compress the pelvis, try to spread it out, and the patient's awake and alert, do you ask them where they experienced the discomfort?
Yeah, absolutely, absolutely. So typically I'll talk to the patient, as you say, tell them what we're doing. Typically my hands are on the iliac crest, and then I'm trying to externally rotate or internally rotate. I like to tell my residents that, you can do an exam for instability, but once you determine it's unstable, you don't need to continue the exam, right? You can stop at that point. And so, but in this case, the other thing I always talk about is there should be some conjugate motion, meaning if I push down on the left side, the right side should come up. Right, so there should be that continuity of a ring that you're expecting to feel when you do that exam. So you think it's stable or it's somehow moving or unstable.
Do you remember what your exam was with this patient?
For this guy, it was going out. It was no tenderness at all. Coming in, had a little bit of posterior pain. And you can see, anybody see anything going on in the rami in this example? Going to drag the audience into this whether you like it or not. Anything in there? So we have, right, bilateral superior rami, and there's probably inferior there, and maybe something on this. It's hard to tell completely, but it's got bilateral injury, so it's definitely a bony injury of some kind. And then here's our inlet and outlet view. We want to go ahead and get complete imaging. Of course, we're lucky enough to be able to get a cystogram at the same time. That's helpful for our imaging. You've never seen that before, I know, in your emergency room. So here we go. So would you consider this displaced or non-displaced? Largely. Non-displaced. It seems like everything's roughly where it ought to be. There's those rami fractures we talked about, and there's a little bit of displacement and so forth. Okay. So, yeah.
The audience may already be aware of this, but there's some subtle information in a lot of these images. So, for example, with the contrast in the bladder, you get an outline that can show you where there's hematoma. So
right.
That'll point you to maybe something you don't see in the bony skeleton.
Right, so you're seeing a compression on this side of the bladder is what you're pointing out. Okay. So What do you think about this? You're taking care of this patient. Do you think this needs operating? Is this something you're thinking about and he's going to need fixation? Who would like to fix this fracture?
Do you have a CT scan so we can?
Well, no. What I told you was it's an incomplete sacroiliac fracture on the left.
I don't believe it.
Okay, well, I'm sorry.
I gotta see it with my own eyes.
Well, and I appreciate that about you, Trig. That's a wonderful characteristic you have. But for the rest of you who are willing to trust me, do you want to operate on this or not?
No, I wouldn't operate on him. I'd get him out of bed a couple times and repeat his exercise.
Okay, would you tell him full weight bearing or partial or weight bear is comfortable maybe? Kind of use a walker or crutches or whatever they might need, and okay, fair enough. So what kind of follow-up? Would you let this guy go home from the ER, or would you keep him overnight, or would it depend how well he gets up and walks? Would that matter to you? Might, if he's not able to really walk well, you might keep him overnight and see what's going on the next day, or that kind of thing. Post-mobilization X-ray, okay.
So usually they get admitted and they get a post-mobilization.
Okay, good. Okay, does anybody do anything different? Anybody sending these home out of the ER?
How about an MR?
MR? What about an MR? Did you get those? Okay, just curious. You wanted a CT, I thought maybe I'd up you for an MR. I was just curious. Okay. Right, so in theory, an MR might show you some soft tissue, but it shows you a lot of things, so it may show you some things you don't want to see, too. Fair enough. So to me, I think one of the bigger questions is what happens if weight bearing is painful, and even though you keep them overnight, you can't mobilize. And that's for me where I would dig in and do a little bit more workup. I'd probably repeat my CT and repeat my post-mobilization images and make sure that I haven't missed anything and things are there. And I think there's some argument that maybe this is a realm for fixation in some patients, but that's fairly controversial. Okay. Fair enough. So in this particular patient, he went on to heal okay. This is a 12-month follow-up. Just to show you that. I do have that trig. I don't have his post-CT, but I have his follow-up film. So anyway, okay, first case.
So eventually he was able to get up and...
Yeah, he got up overnight and went home post-injury day 1. Followed up a year. Yep. So here's case 2. 30-year-old has a 1 hour after motorcycle accident. His blood pressure is 100/60. Usually we talk about blood pressure less than 90 being concerning, and heart rate's up a little bit. He's hurting. Here's a picture. Does that concern you a little bit? I think his pressure may not be up for long, huh? Okay, so that's what do we see? Anybody want to describe that?
I think there's a little separation of his pubic symphysis.
There's a pubic symphysis diastasis, okay. Dr. Borelli offers there's a pubic symphysis diastasis, which there certainly is. Is there anything going on in the posterior ring? It has to be, doesn't it, to be this kind of diastasis. There has to be some mobility here, doesn't there? But it's deceptive. Interesting. This is very externally rotated here. Okay. So let's see what else we have. So during the establishment of access, you're trying to get your IV lines, and his blood pressure drops, his heart rate goes up. So that tells us, what do you think that tells us about this guy? He's bleeding. He's having hypotension. Now, of course, you know, what ATS will tell us is that even though that's true with this kind of a pelvis, still an injury to the abdomen is the most common cause of life-threatening bleeding, even though this is important and something we have to manage and be part of the resuscitation. Fair enough. So his systolic blood pressure is less than 90, unresponsive to fluids is generally how most people will talk about hemodynamic instability. And of course, shock on admission is a big red flag. So it's most reliable predictor of an elevated ISS, of transfusion requirements, and mortality if we're not careful. So in ATLS speak, there's all these different reasons it'll cause hypotension, and of course we're concerned with the hypovolemia aspect in this particular case. And of course there's these 5 places you can bleed with ATLS, right? In the chest, in the belly, in your extremities, on the ground, or in your retroperitoneum. And so that's certainly a concern for this case. So there we are again. So what kind of things do you want to think about for resuscitation? Obviously, we want fluids, we want coagulation, and I would say one of the things that's changed in fluid resuscitation in my time is as I started, this was all IV stuff, and now it's much more of a one-to-one resuscitation of unit of blood to unit of factor and this kind of thing, where people never thought about FFP and cryoprecipitate and these kinds of things when you're resuscitating when I was a resident, but much more so now because recognizing filling people with blood and saline that doesn't clot is not a good strategy for these folks. Okay. All right, excellent. Right, he needs some stability. Thank you. Appreciate that. That's wonderful. Okay, so we think about the AP pelvis is enough right now and you're in the ER. We're going to need other things later on to figure out what to do about it. But for right now, it's enough. And to your point, right, the anterior-posterior compression, there's this axial loading along the axis of the skeleton, and it externally rotates. You can see the external rotation here in this picture. And so here we go, an AP compression injury. We've seen about those in talks. We hear about them. We saw this case, increased incidence hemorrhage and GU injuries and all kinds of things. So, right, so we can use a sheet or we can use a commercial binder. You can see that here. What do you think about how they're located? What's positive and what's negative? When you think about what you tell your residents, Joe, where do you tell them to put your binder?
A little bit lower than that sheet, certainly get it up on the greater trochanter, get it on the greater trochanters and squeeze like hell. Now this guy, if that was an actual clinical picture from the emergency room, sometimes just bringing the legs together and tying their feet together.
Right, that can help a lot, right? Just that internal rotation of the feet. But
I like to get it down on the greater trochs,
right,
at least.
right. Because how many of you all have commercial binders in the ER for this kind of thing? How many of you ever used a binder or a sheet for this? Excellent. Good. Thank you for that. Right, so the binders and sheets are easily applied. Right, they're portable, versatile. You can convert them to an X-fix or fixation later. The downside to them is that where they are, as Joe was alluding to, they can block access sometimes to the belly, sometimes to the femoral vessels for angiography. And sometimes they can hide soft tissue injuries, or if you keep them on for more than 24 hours, might create a soft tissue injury or two. So things to think about with binders. They're important, they're a useful tool, but they're not the only answer. Right, so prior to, he's got an acute abdomen, he's going to the OR for an X-lab. So what do we think about? Is it important to do anything with a pelvis like that when they're going to the OR? What do you think the problem is with doing a laparotomy like that is? Right, so there's a comment. So basically the problem is that your anterior abdominal wall gives lots of stability to the pelvis. So if you do a laparotomy, you'll increase the diastasis. Right, so most people talk about helping, you have to honestly be pretty aggressive with a general surgeon who's in fairness trying to save the guy's life. But you also want to explain to general surgeons that you can help stabilize the bones while you're saving the life so you don't make things worse. Right, and then it becomes, what are we going to do? We're going to do an X-fix, we're going to do a C-clamp. What options do we have? How many of you have done a pelvic C-clamp? Okay, a couple. How many of you have done a pelvic X-fix? Okay. And I like to tell my residents with an X-fix, you put the pins in, but somebody else has to do the reduction, right? Because the X-fix itself isn't the reduction. That's something somebody else does, and you fix it in that position while the reduction's happening. Okay? So the article that most people talk about is Alex Ghanayam's article, and it's an old one. It's 30 years old now, but that was the article that basically said if you had a cadaver and you did a pubic symphysis diastasis and left the abdominal wall alone, you did an SI joint and pubic symphysis diastasis, you got about 3 to 4 centimeters of diastasis, and if you opened the belly, it went to 10 centimeters. So the point was that the abdominal wall contributes a lot to pelvic stability. So it's just that reminder to us that we need to have surgeon-to-surgeon communication. Usually in the heat of battle, so to speak, it doesn't do well to go through the residents or go through the staff. Yeah, it really takes surgeon-to-surgeon communication to make this happen. So an X-Fix has lots of advantages that we talked about. It has relatively poor control of the posterior ring. Fair enough. The C-clamp has lots of advantages, but may give you some wound problems posteriorly, and you really need two people to put it on properly because it's hard to maintain that in position with one person to try to do that. So here's our CT. Trig, there's a CT for you. And so looking at this as we're thinking about the resuscitation down the road now, what kind of reduction techniques do you want to do? This something you might just be able to derotate into position, or?
Yeah,
Looks like.
On the flame films, the left hemipelvis seemed a little crossing migrated, but here it looks like
Looks, of course, it can be deceptive, but it looks like something you might be able to just rotate and close, particularly early on before things get too filled with hematoma. So this is a case that ultimately underwent open reduction anteriorly and closed percutaneous fixation in the back. Now, this is, I think, we would argue today, this is an older case. Those screws are too short. Most of us would say those screws are too short and they need to be across the body for a sacrum. But I think it's worthwhile mentioning that that's a change that's happened over the years. When we started pelvic fixation, this would have been the standard, and today it would be a transsacral screw that would be the standard. Okay.
Another progression you showed with the X-Fix X-ray. And I've struggled with putting these pins in. It seems like I still have nightmares about them, but the two lower ones, that supraacetabular pin, that has been a nice metamorphosis as well. Remember, we always used to go for the crest, but that damn crest is so thin, it's hard to get them in between the tables. If you do happen to push on the pins and not the pelvis, you can tear them out from the table. But those superior, and they could be a little lower, but those shan't screws.
These two.
Yeah, inferior spine, those.
Right.
And back towards the sciatic, buttress and sciatic notch.
Okay. All right.
They made a big difference.
Okay. Any comments?
Anybody still using the C-clamp? Is it still around?
Yeah,
Has it? Yeah.
it's actually good for help with reduction, and that's when I've used it.
Kind of stabilize the back.
Stabilize, especially if I've got a combination of injury with the pelvis and an acetabulum, I can stabilize it, put screws in, and it makes my acetabulum reduction easier.
So as a young traumatologist, I ended up taking pictures of the cases that go to the OR and had all these resuscitations and this and that. I realized for you in practice, the pelvises that need resuscitation are a minority of cases, but the bony instability is still relevant, so we can talk about it. So in this case, 24-year-old pedestrian versus auto has a tense abdomen. He's hypotensive. You detect some motion in his pelvis. And any comments on this X-ray? Dr. Borelli's observation that pubic symphysis is diastase.
Looks a little wide.
Not quite as wide as the other one. Not quite as wide as the other one. It looks like there's possibly a little separation on this side of the SI joint, and maybe it's a little elevated. It's all pretty. Anything interesting going on in the hips? It's kind of easy to overlook that, isn't it, when you're looking at the diastasis, that hip dislocation with a Pipkin fragment right there. So he goes to the OR, he gets an X-lap, he gets a splenectomy, and this was the case when I was at UC Davis, and so it happened to be a case where, because I was there, right, talking to the general surgeon, they said, well, you know, we're going to be right there. Why don't you just put a plate on the pubic symphysis, be done with it? And so I said, okay, we'll do that. That's not typical, but that can happen if you're right there at times. So he comes, and here he is. So he's got persistent drop in hemoglobin levels, although his pressure's okay. And so we ended up going to angiography, and he had a little blush down here that people treated and seemed to help. So my question really is this, so here's our CT post-fixation down below, and there's our plate. So how do you classify this ring? What would you call this one? It's like an anterior-posterior compression, but what stage is it? quiet group. I would call it a stage 2. Andy votes for 2, right? So it's just an example that they do exist. In order for a condition to be rare, it must exist. So they're in order. That's right. So we don't see them that often. So many times it seems like you plate the front. And interestingly, in this one, he has a displaced superior ramus fracture, just a very low anterior column acetabular fracture on this side after the hip's reduced, which is subtle and hard to pick up, but yet it maintaining good reduction, and his SI joint seems appropriately reduced. So this is one where he didn't feel like he needed further treatment.
So we used to imply that the inguinal ligament was helping us out.
Right.
On the left side.
Yeah, the inguinal ligament, which runs from the pubic tubercle to the ASIS right there. Yeah, that's where the soft tissue's coming from to pull them together. That's exactly right.
Banked a lot of my stability on soft tissue.
Yes. Part of the abdominal wall, that's right. Okay. Well, Joe, you want to go to Kyle, or what do you want to do?